Thank you very much, Phil. I appreciate it. Nice introduction, and hopefully I'll figure out how to work these slides. When I'm there, that's probably here we go. So what I'm going to do is probably cover some of the material you actually heard about. Well, I know I will be covering some of the material you've heard about in the last several hours. I'm going to present an overview of the findings from the review that I did on contract for the Heinz endowments regarding studies that have been published on Pittsburgh air quality and health. I'm going to provide you the conclusions of my assessment of looking at that literature. And then I was asked to also discuss a little bit about how air quality standards and guidelines have changed over time based on how the science has developed, and what the implications are for Pittsburgh in terms of both air quality and health and air pollution control efforts. So as I mentioned, I was contracted in August of last year to review the scientific peer-reviewed literature as well as technical reports, and I'll talk about my criteria for review in a second, that really focused on studies that had published in their published literature results for Pittsburgh with respect to air pollution and health. And I wrapped up that study earlier this year, and it was published in the last couple of months, actually in March of this year. So my methodology was to do a review of the scientific and technical literature. I focused on publications after 1970 because the air pollution and health literature prior to 1970 really, there's some real questions about how relevant some of that data is to today's world. And I used a methodology that's been recommended in the World Health Organization's document, The Evaluation and Use of Epidemiological Evidence for Environmental Health Risk Assessment, which was published in 2000. I did a review of the usual search websites, PubMed, Google Scholar, Web of Science, and Scopius, among others, using terms such as Pittsburgh air pollution health and variations on those terms. And I did include, at least initially, technical reports that had used what I would term commonly accepted analytical methodology, and that also provided specific air pollution and health data or risk data for Pittsburgh and air pollution health levels. So this was not a meta-analysis, so I didn't analyze all of the data together. What I did was a qualitative weight of evidence assessment based on this body of literature that I identified through this systematic review. And then in order to assess that qualitatively, I used the criteria that you see posted here. So, and these were drawn from a variety of sources that I can go into in detail if you guys want to talk about it. But basically, was the study population adequately selected, and whether in fact a positive association was identified in that study? Were strong biases ruled out or unlikely? Were confounding factors controlled or likely to be limited by the analytic approach? The quality of the exposure assessment. How good was the exposure assessment that was done in terms of actually generating the air pollution data that the health outcomes were assessed at? And is there a biological basis indicated for the health outcome that was assessed? And I looked also particularly in detail at the multi-city epi-studies with positive and statistical significant associations for Pittsburgh, but also gave even more weight to the studies that not only found a positive association for Pittsburgh, but also when they combined cities, as Dr. Domenici just discussed earlier, did that combined analysis also give you a positive result that was statistically significant. So these are going to be difficult to read. These are extracted from the report, which is, I think, available outside if you want a copy. It's also available on the Heinz Endowment's website on their publications page. But this gives you some idea of what was included in the report. So you see the study and author, the pollution that was examined, the pollution data that was examined, including when that data was generated. Was there a positive result for Pittsburgh? And was that result statistically significant or not? And then some comments about that study which were essentially just very, very quick abstracts of some of the key aspects of the study. The report also included in an appendix much more detailed information on all of the studies that were included in this report, but those are actually not in the published version. They're on the website in another appendix. So as you can see here, there were a number of studies, including some by Dr. Domenici, and you'll see also others by Dr. Schwartz mentioned shortly, and there are quite a few. And you'll see that almost all of the studies, and I'll get to this when I wrap up, almost all of the studies that examined Pittsburgh air pollution and mortality found a positive result, and many of them were statistically significant. Most of these studies were multi-city studies. And you can see here just some examples, just going back, 95 cities, which was the NMAPS data that Dr. Domenici just talked about, 20 cities, which was the initial cohort of cities for NMAPS that Dr. Domenici and others at the time looked at, 88 cities, 10 cities, and so on. So you see that a lot of these studies were multi-city studies that had the advantages that you just heard about from Dr. Domenici. In terms of morbidity, you'll see here again that, that there were a lot of studies. The difference here, though, in the morbidity studies is we had many more studies that focused just specifically on Pittsburgh and were not part of larger, multi-city studies, although some were. Including the NMAP study that you just heard about earlier that looked at a subset of 14 cities, for example. And I did include some older studies as well, including, interestingly enough, a study of an air pollution episode that occurred in the 1970s in which, in Allegheny County, there was a major air pollution episode that occurred in actually the wintertime in November of 1975, and there was an analysis of lung function in students. And so I did include that in this analysis, although that is certainly older data, but I think it's interesting. It gives you some idea of some context for the history here. But most of these are much more recent studies that examined these health outcomes. Again, a variety of morbidity. Most of these are hospital admission studies. One study I thought that was particularly interesting because it really goes to the kind of analysis that Dr. Schwartz talked about earlier today at lunch, which is what happens when we see a dramatic reduction in air pollution due to some external factor. He talked about the closing of the smelters in the Southwest as one example. Dr. Arden Pope published another study in Utah Valley where a steel mill was closed, and they looked at hospitalizations before and after. So here was a study also by Zhu et al. In 2008, which looked at the closure of a coke plant here in Allegheny County and the reduction in PM10 that occurred. And they compared pollution levels before and after the closure in terms of hospital admissions for cardiovascular causes, and did see a statistically significant result from that before and after comparison. So those studies are very interesting in terms of giving us an assessment of what happens in the real world when there's a reduction in air pollution that's fairly dramatic. Birth outcomes, you just heard about these studies from Dr. Talbot. Again, all of them were positive and all of them were statistically significant in terms of their outcomes. And I also looked at some reports that were prepared by Carnegie Mellon University that they prepared for the Allegheny County Department of Health, as well as some published papers that came out of that work as well that looked at toxic air pollution or hazardous air pollutants. Those are pollutants like benzene, xylene, toluene, nasty stuff that cause birth defects, that cause neurological problems, reproductive outcomes. These are not what are called the criteria pollutants that you've heard about for most of today. These are so-called hazardous pollutants that are regulated under another section of the Clean Air Act than the criteria pollutants. They're often referred to as toxic air pollutants. Not that the other pollutants aren't toxic, but these hazardous air pollutants are typically called toxic air pollutants. And these looked at risk estimates based on estimates of the risk of cancer or non-cancer outcomes associated with exposures that were measured in the Pittsburgh or Allegheny County area. So what did we find looking across pollutants in terms of the number of studies? Looking at PM10, they were not surprisingly, because a lot of the data that was available when these studies were conducted in the 1980s and into the 1990s and even into the 2000s, the most robust data source was PM10. Because PM 2.5 data, for the most part, didn't really get monitored and collected until about 1999 or 2000 in that period. So a large number of studies were PM10 studies that looked at mortality. Almost all of them, in fact, all of them showed a Pittsburgh positive result for mortality. Not all of them were statistically significant. I'll go into that in a minute as to why that might have been the case. In morbidity, again, all of the ones for PM10 for Pittsburgh were positive. Most of them were statistically significant. Birth outcomes, all were positive. A couple were statistically significant. PM 2.5, or COH. COH is coefficient of Hayes. Coefficient of Hayes was an old metric used in the 1970s and early 1980s as a measure of light scattering, as a way of measuring fine particles, actually. They correspond very well to fine particles because it's the fine particles that cause the light scattering that causes the sort of hazy effect that you see in the sky. And that was the measurement. Before we had PM 2.5 measures, that was the measurement that was used that corresponds best to fine particles. And you see here the results for mortality. Most of the studies were positive, and some were statistically significant. Birth outcomes, same as well. Ozone, a little bit more of a mixed situation for mortality. Of the studies that looked at Pittsburgh, about half were positive. None were statistically significant. Again, I'll get to that in a second as to why that might be. Morbidity, again, less of a positive result for ozone, but birth outcomes, again, very robust in terms of finding Pittsburgh results that were positive and statistically significant. And all the studies that looked at these toxic air pollutants, these hazardous air pollutants, found a cancer risk for the Pittsburgh, Allegheny County area that exceeded the risk that EPA, the US EPA, typically uses as its benchmark, which is about 1 in a million excess risk. So, just summarizing the report findings, I found 32 peer-reviewed journal papers and 3 technical reports published after 1970 that had Pittsburgh air pollution and health data. About half of the reports focused solely on Pittsburgh or the Pittsburgh metropolitan statistical area. The remainder were these multi-city studies that you've just heard about from Dr. Domenici. Of 18 epi-studies assessing Pittsburgh air pollution and premature mortality, almost all of them were positive, and about half of them were statistically significant. And of the 12 epi and field clinical studies that assessed morbidity effects with exposure to one or more of the pollutants that we've just talked about, particulate matter, ozone, other pollutants, 11 found a positive association, and about 2/3 were statistically significant. All of the studies on birth outcomes or measurements of upstream conditions related to increased risk of adverse birth outcomes found associations with one or more of the following pollutants, PM10, PM 2.5, and ozone, and all of them were statistically significant. All of the studies that looked again at cancer and non-cancer health outcomes found cumulative cancer risks. So these are risks not just from each pollutant, but when you combine all of these toxic air pollutants together and look at their cancer risk and non-cancer risk related to other nasty health outcomes, they exceeded EPA's thresholds for concern, for risk concern. And in reviewing the literature, identified, and this was not fully inclusive, but identified, just looking at the literature, at least 18 additional studies, and you've heard Dr. Schwartz, I think, reported on one earlier at lunch, that included Pittsburgh air pollution data, but didn't actually report the results of the Pittsburgh data in the published literature, so I couldn't include it in the report. But what it says is that there's a much more robust actual compilation of air pollution and health studies that have Pittsburgh air pollution data. It's just that they're in these large multi-city studies, and because of page limitations and the limitations of how you present the data in these studies, you can't present studies for 100 cities or 20 cities or 80 cities. So there is a lot more data out there. It's just that the Pittsburgh results weren't included in the published literature. So I think in terms of continuing the report, the summary report findings, the majority of the studies in the review, most of which were based on this standardized increase in air pollution levels, which typically was something like a 10 microgram per cubic meter increase in daily PM 2.5, found positive risks for Pittsburgh air pollution exposures. Though some of the positive associations were not statistically significant, and I think this is an important point to keep in mind. The small numbers of daily deaths and hospital admissions for cardiopulmonary causes in individual cities, including Pittsburgh, in these daily time series studies can constrain having sufficient statistical power to find a statistically significant result. I think that was one of the points that Dr. Domenici just made earlier, which is that looking at these multi-city studies, you can combine cities and get a much more robust statistical power in your studies by looking at that. So it's not surprising that in some of the studies that looked only at Pittsburgh that we didn't see statistically significant results, although many did. And all but one of the multi-city studies that examined Pittsburgh PM and ozone mortality found statistically significant associations when data for all cities that were considered in the analysis were combined. So, what did I conclude from looking at this data set of published studies in a more qualitative way? Well, what I found was a largely consistent basis of evidence that exposure to Pittsburgh air pollution at levels that are reasonably consistent with what we're seeing today in terms of standardized increases in air pollution resulted in an increased risk of adverse health effects. And these included premature death, particularly in the elderly and those with existing heart and lung disease, exacerbation of lung and heart disease resulting in hospitalization and emergency department visits, as well as adverse birth outcomes. Another point is one of the concerns that people sometimes bring up with studies that have used older air pollution data is, well, those was air pollution levels, back in the 1980s or back in the 1990s. That's not what's happening today. And how do you know the air pollution levels that we have today are a cause of concern? You heard some of that response, I think, from Dr. Schwartz earlier this afternoon. But the reason that I would certainly suggest that these results are valid for today's air pollution levels in Pittsburgh is that we now understand, and you've heard about this a little bit more previously, is that we're looking at a relatively linear dose-response function between the relationship for outdoor air pollutants such as PM 2.5 and ozone and some of these really serious adverse health effects that we're concerned about and are finding in these studies, like premature mortality, like hospital admissions, like emergency department visits. And that is, so essentially, that even as we go down to lower and lower levels, we're still seeing an increased risk, and that when we utilize a standardized level of increase in pollution, no matter where in the range you're looking at, you still find consistently statistically significant results. And again, as I mentioned, the estimated lifetime cancer risks from the analysis of hazardous air pollutants, toxic air pollutants, all show that this area, and those data are more recent, they're in the 2000s, show that this area, when you combine those risks together, exceed EPA's pollution threshold risk level of 1 in a million. So I wanted to just, I'm going to have to go through this really quickly. EPA does a review of air quality standards every 5 years, and I'm going to get into that a little bit more. But I wanted to show you, this is from the most recent reviews that EPA has done on particulate matter and health impacts, what they call their causal determination, their review of the science and how close they feel the data is to providing a causal determination that the association between the pollutant and the health outcome, in fact, is a causal determination. I've highlighted respiratory effects because this is World Asthma Day. You have talked a lot about asthma. So what you can see here is that for PM 2.5, for short-term exposures, respiratory effects are likely to be causal and are likely to be causal for long-term effects for PM 2.5. whereas for the coarse particles, we still are much more in the suggestive or inadequate categories. For ozone, it's even more apparent that there's a strong relationship between ozone and respiratory impacts. You see here lung function decrements both in healthy exercising adults and children with asthma, airway hyperresponsiveness, pulmonary inflammation, injury and oxidative stress, symptoms and medication use, again, primarily going to be in asthmatics as well as people with COPD, and hospital admissions and emergency department visits. All of these are causal for short-term ozone exposures. Asthma hospital admissions and new onset asthma are likely to be causal for long-term exposures. So I wanted to just share that with you because I think it's important for you to understand that when the US EPA reviews the entire body of evidence based on their expert scientists that provide them input, that this is kind of how they parcel out the data in terms of what's causal and what's not. So in terms of setting air quality standards, the Act requires that these standards be set with an adequate margin of safety to protect public health, and that cost and feasibility of attainment cannot be considered in that part of the review. And that was upheld by the US Supreme Court more than a decade ago when they reviewed a lawsuit brought by industry against EPA for setting the particulate matter and ozone standards in 1997. That review has to be done at no more than 5-year intervals. It has to be based on a compilation of current science, which are called the criteria, thus the term criteria air pollutants. And that criteria includes atmospheric chemistry information, exposure levels, health effects, including a focus on susceptible populations, and a risk assessment for different alternative air quality standard levels. And that information is all reviewed by an independent body of scientific experts called the Clean Air Scientific Advisory Committee, or CASAC, that provides recommendations to the EPA administrator on that revision. So just a little bit of history on EPA standards for air quality and other guidelines. You heard about this already this morning a little bit, but I think it's worth going through. The major point here being that as the science has progressed, the standards that have been adopted by EPA and the guidelines that have been adopted by the World Health Organization here have been substantially lowering as time goes on. And here you see it for ozone. We started out in 1997 with an 8-hour average standard at 0.085 parts per million. EPA is now at 0.075, which actually contravenes the recommendation from their expert scientific committee of setting a standard between 0.06 and 0.07 parts per million. You can see here for PM 2.5, the standard, the annual standard was at 15. WHO already was at 10 in 2005 for their guideline as being health protective, and a daily standard that was much lower than EPA's. CASAC recommended, and I was part of this review, an annual standard of 13 to 14 and a daily standard of 30 to 35. EPA ignored us in 2006. It kept an annual standard of 15, dropped the daily to 35. CASAC again reviewed it more recently, dropped the recommendation to 11 to 13 for the annual standard and the daily at 30 to 35. And EPA just last year, at the end of last year, adopted a new annual standard of 12, which was in the range of CASAC and kept the 35 daily. So again, as the science has progressed, the standards have gone down. So the conundrum for EPA, and for those of us that are worried about this whole issue of air quality and health, is how do we set standards that are adequate with a margin of safety to protect public health for pollutants for which we really have a tough time finding a level that's quote-unquote safe. In other words, there's no effect at that level. And as you'll see, we're supposed to be protecting sensitive groups. And this is from the actual Clean Air Act of 1970. This is the language in the legislative history about protecting statistically related sample of persons in sensitive groups. And you're actually supposed to be being able to protect a deviation of impact on any person in a group in a statistically representative sample. So a very tough calling. And this whole issue of a margin of safety came about. John Middleton was the commissioner of the National Air Pollution Control Administration, which was the predecessor to EPA. And he talked about the need for margin of safety because other environmental factors, like things like heat, might impact people's health as well as air pollution. And the legislative history says that there needs to be a degree of protection against hazards that haven't even been identified. So we need a margin of safety. And Dr. Middleton also pointed out that there's this, even more than 40 years ago, this issue of threshold effect is going to be very difficult to handle. He says that as the science progresses, it's very likely we're going to find still other body chemical systems that are being affected, since the no effect level always corresponds to the limitations of scientific knowledge. And I've just talked about the fact that as scientific knowledge has improved, the standards have dropped accordingly. And Ed Muskie, who was one of the key senators involved with the Clean Air Act, talked about the fact that there is no such thing as a threshold for health effects. Even at the national primary standard, the primary standard being the health standard, there are health effects that are not going to be protected against. So there was recognition early on when the Clean Air Act was developed that we're going to have a really tough time protecting everybody in the country against air pollution health effects. So here you have, you saw some of this information before. You have Pittsburgh air quality monitoring data. This is PM 2.5 data for annual averages. And you can see they've been going down. Liberty, of course, stands out as the worst actor here. And that's been dropping as well. But here you see the annual standard as it previously existed at 15. Here you see the CASAC standard that was adopted at 12. But here's the WHO standard that was adopted in 2005 of 10. All of the Pittsburgh monitors are above that. So how much of a margin of safety is there in the standard for at least some subset of the population? You can see the same thing here. This is the same story, very similar with the daily PM 2.5 levels. Yes, there's been significant improvement in what's going on in the Pittsburgh, Allegheny County area here. Again, Liberty stands out as the worst actor. But again, they're just starting to approach the WHO recommended level. And here's Liberty in more detail. I think I'm going to skip this. I think you got the message about this. It's certainly the bad actor. Here's the same thing on ozone. EPA hopefully will be revising the ozone standard as well. Lisa Jackson, the former EPA administrator, tried to do it, was overridden by the president in moving forward with her recommendation to revise the standard somewhat lower than the 0.075 part per million. CASAC's recommendation was here. WHO is down here. And here's where the Pittsburgh monitors are. So what does this mean looking ahead for Pittsburgh air quality and health? I think what we're going to see is that serious adverse health effects will be found at increasingly lower levels of pollution. And I think we've learned from history that as the science progresses, we're finding adverse health effects at lower and lower levels. The number of people that have been identified as at particular risk from air pollution will also likely increase. And that's because, again, we're understanding more information about who else is at risk. It's not just sick people. It's not just people that have acute, very serious heart disease and respiratory disease. It's diabetics. It's people that are probably obese. It's people with genetic polymorphisms that make them more at risk to air pollution. There's stress. Dr. Schwartz talked about some of the studies that have been done in Boston on air pollution and stress. Nutritional status also affects your ability to fight air pollution. So I think air pollution control needs to be viewed as a continuous progressive effort to improve air quality in the most efficient, cost-effective manner that maximizes public health protection while ensuring equitable protection for those most at risk for adverse health effects. And I know I've gone over time. I apologize. So I'm going to wrap up there, and I guess we'll have to save questions for the panel discussion, right? Okay, thanks.